Hello everyone, I'm Mandana Donahue from Oral Pathology 360 and we are here today conducting the 7th Journal Club with authors. Oral Pathology 360 is your one-stop online resource for everything related and everyone related to oral diagnosis and management of oral and maxillofacial diseases. Today, we also have a special announcement. Those who are members of the channel can get a certificate at the end of the session. Stay with us till the end. I will tell you how. To get the most from the event, remember to watch it on high resolution and from within YouTube and not the many apps it's available on, because you can then interact with us, put your questions, and interact with us live. Also, if it's your first time here, please hit the subscribe button and turn on notifications so you don't miss anything from us. Now, let me bring in our host, Dr. Pouyan Aminishakib, who will introduce our amazing guests and get the whole program moving on. Welcome, Dr. Pouyan.
Hello, Vandana. Thank you very much. And thank you, Oral Pathology 360, for the opportunity. Uh, I would like to introduce the contributor of the program today. It's a great honor for me to introduce Professor Sven Niklander, the first author of the paper today. He's a professor at the Andres Bello University in Chile, and also he's associate editor of Oral Diseases Journal and also Journal of Oral Pathology and Medicine. Thank you very much, Sven, for joining this program.
Hi, Puyan. Hi, Mandana. Thank you for the invitation. It's a great pleasure to be here. It's an honor as well to see the paper presented. So thank you very much. Very happy to be here with you today.
Thank you for accepting my invitation. Also, it's a great honor for us to host Professor Keith Hunter. He's professor of head and neck pathology at Liverpool University, and also he's president of British Society of Oral and Maxillofacial Pathology. I would like to express my sincere gratitude to you, Professor Keith, for accepting my invitation. I know you are well experienced in cellular aging. You have published several papers on this topic, and I'm sure we will have a great discussion about the details of this paper. Thank you.
Thank you, Pouyan, and it's always my pleasure to come back on Oral Pathology 360 and to link in with the folks in Tehran. Let's talk about some good science and some good pathology. So it's always a pleasure, and it's good to see you all.
It's very kind of you. And also, it's my pleasure to host Dr. Hana Safar again. She's associate professor at Cancer Institute Hospital, Tehran University of Medical Sciences, and she kindly supervised our residents in this program. Thank you, Dr. Safar, for accepting my invitation.
You're welcome. Hello, everybody. Thanks for your invitation. I'm really honored to participate in this informative journal and this very interesting topic.
Okay, thank you very much.
Uh,
And also, we will have two interesting presentation by two passionate, talented residents, Dr. Masoume Qomi and also Dr. Aysan Nozheh. Thank you, Masoume, and thank you, Aysan, for joining this program. We are waiting for your presentations. Thank you. Okay. Let me share the title of the paper of the program with you, and we will immediately go to the first presentation by Masume. The title of the paper is Aging and Oral Squamous Cell Carcinoma Development, the Role of Cellular Senescence. And we are waiting for the first presentation by Masume. Okay, Mandana, we are
Hi everybody, my name is Masoume Qomi. I'm an APC president at Tehran University of Medical Science, and it's a great honor to be here and participate in this presentation. Today we're gonna discuss about an article named Aging and Oral Squamous Cell Carcinoma Development, the Role of Cellular Senescence. Here we will review general aspects of cellular senescence, more focusing on the relation between senescence-related inflammation with cancer development. We also analyze the available evidence linking cellular senescence with oral squamous cell carcinoma. Cellular senescence is a state in which the growth capabilities of cells are irreversibly lost in response to different stressors. And these senescent cells develop an inflammatory secretome by changing their gene expression profile called senescence-associated secretory phenotype, or SASP. These secretion of inflammatory factors as part of the SASP can act on neighbor cells, leading to either predisposing, triggering, or promoting the development of different diseases. And therefore, accumulation of senescent cells can be detrimental, influencing many age-related diseases. This led to the development of new type of drugs known as senotherapeutics, including senolytics that are drugs aimed to specifically target and eliminate senescent cells, and xenomorphics that decrease the abundancy of inflammatory factors present in the SASP. Stromal senescent cells and epithelial cancer. There is robust evidence supporting stromal senescent cells as promoter of epithelial cancers of different origins. Recent studies have also suggested senescent cells play a role in oral cancer squamous cell carcinoma development, progression, and therapy resistance, and thus could have an impact on the way we currently treat oral precancerous lesion and oral SCC. Cellular senescence. Senescence can be induced by different stimuli, including replicative stress, oxidative stress, oncogene signaling, and DNA damage. And there are 5 hallmarks of cellular senescence, representing structural, epigenetic, and signaling alterations, including 1. Chromatin reorganization, 2. Cell cycle arrest, 3. Metabolic adaptation, 4. Modifications of the lysosomal compartment, and 5. Development of a secretory phenotype, or SASP. Senescent cells markers. The most used markers are the activity of senescent-associated beta-galactosidase, the expression of lamin B1, P16, and P21, identification of senescent-associated heterochromatin foci, accumulation of DNA damage response proteins such as phosphorylated H2A, and many others have been reported, including the lack of expression of Ki67 and the increased secretion of interleukin-6 and interleukin-8 SASP factors. And the point is that there is no universal marker to identify senescent cells, and none of the aforementioned features can be used by themselves to identify senescent cells, and a combination of 2 to 4 of these markers should be used. Senescence effect. Senescence, depending on the context, can have both beneficial and detrimental effects. In young individuals, it contributes to tumor suppression and wound healing primarily by stopping the cell cycle and by secreting specific factors as part of the SASP. But in older individuals or upon consistent and chronic damage, it can cause tissue dysfunction, chronic inflammation, and age-related disorders, including cardiovascular diseases, fibrosis, diabetes, neurological disorders, and paradoxically cancer. And all of these negative effects are attributed to accumulation of senescent cells and the SASP. Cellular senescence as epithelial cancer promoter. The pertumorgenic effects of senescence are explained by the SASP. In fact, non-cancerous senescent cells or cancerous cells induced to senesce because of therapy, either radiation or chemotherapy, secrete soluble factors that can be used by perimalignant or malignant cells for their advantage. Regulation and composition of the SASP. Based on different experimental models, SASP varies between cell types and the senescence inducer, and the expression of the SASP is more influenced by the cell type rather than the senescence inductor, as we discussed earlier about it. The composition of the SASP is widely heterogeneous, and more than 50 different soluble factors might be overexpressed. And there is substantial overlap among SASPs, with the specific proteins being almost invariably, including interleukin-1 alpha, interleukin-6, interleukin-8, MMP1, MMP3, MMP10. Virtually every cell that senesces will develop a SASP. But there are reports from animal studies in which, under specific conditions, cells senesce without developing a secretory phenotype. And diverse signaling pathways are associated to induce and maintain the SASP, including phosphoinositide 3 kinase, mammalian target of ribomycin or mTOR P38, MAPK, STAT3, GATA4, CGAS/STING, interleukin-1 signaling pathway, and Rho kinase. And all of these pathways have one thing in common, and that is activation of nuclear factor kappa beta and or CEBP beta transcription factors as downstream effectors. Nuclear factor kappa beta is a transcription factor that regulates multiple aspects of innate and adaptive immune functions and serves as a pivotal mediator. As you can see in this picture, nuclear factor kappa beta induces the expression of various pro-inflammatory genes, including those encoding cytokines and chemokines, and also inflammasome regulation. Consequently, the regulated nuclear factor kappa beta activation contributes to the pathogenic processes of various inflammatory diseases. Senescence and carcinoma. Classically, the accumulation of genetic and epigenetic changes in target cells has been considered as the primary cause of carcinoma development. However, that simplistic view has changed, and there is finding that says precancerous epithelial lesions with cancer-associated mutations may never progress into cancer. Also, there is evidence suggesting microenvironmental change can be a final trigger for developing the malignant phenotype. And for these microenvironmental changes, mesenchymal component, or estroma, plays an important role, and so in the tumor pathogenesis. Senescent stromal cells, including fibroblasts, pericytes, adipocytes, lymphocytes, among others, facilitate tumorigenesis of epithelial cancers by generating a tumor-permissive microenvironment, promoting the growth of malignant cells of breast, skin, prostate, colon, gastric, and oral cancers. Sources of senescent cells. We have two sources for senescent cells, TME or tumor microenvironment, and TIS or therapy-induced senescence. Tumor microenvironment or TME. As the organism ages, fibroblast renewal rates start to decrease. Also, senescence of immune cells reduces the clearance of other senescent cells. Therefore, senescent cells accumulate in tissues, resulting in an aged TME with abundance of SASP factors. These factors that accumulate in an aged TME include proteins able to remodulate the extracellular matrix, such as MMPs, plasminogen activator inhibitors, tissue type plasminogen activator, and the secretion of pro-inflammatory molecules and growth factors, such as CXCL1, CXCL8, CXCL2, interleukin-6, interleukin-1 alpha, and colony-stimulating factors. TIS, or therapy-induced senescence. TME is not the only source of senescent cells. Tumor cells themselves can be induced to senesce by chemotherapeutic drugs or by radiation therapy. TIS does not only affect cancerous cells but also stromal cells, and is considered an off-target effect of cancer therapy. Cancerous TIS cells remain metabolically active and together with other stromal TIS cells are a source of chronic inflammation through the SASP, facilitating drug resistance, tumor relapse, and distant metastasis. This was the first part of the article, and the second part will present by Dr. Nozheh. Thanks for your attention.
Okay, thank you very much, uh, Masoume, for your great presentation. And let's immediately go to the question. I would like to invite the uh, audience to share the questions in the chat box, and we will ask them from the expert and the authors. Let me start this part with the general question, Sven. Would you clarify that when we are talking about cellular senescence, we should expect a negative impact or positive impact on the cell? It means that a cellular senescence provide initiation of the carcinoma, or it will help the cell to evade the initiation of carcinoma to change.
Yeah, it's a good question. It depends on the context because when a cell senesces, that cell it's out of the cell cycle, so that cell should not be um, proliferating anymore. So from that point of view, it stops cancer development. But on the same time, when cells senesce, they also secrete this SASP, these inflammatory factors, and those factors can be used by surrounding cells and therefore can promote cancer. So it definitely depends on the context. So it can have both effects. Initially, it was believed that senescence, and it's still believed, it's a really strong anti-tumor mechanism. But now we know that it can go both ways. So it can stop cancer development, but also in a proper context, it can promote cancer development.
Okay, great. Professor Hunter, do you have any comment to add to clarify on the role of solar senescence on the initiation of the carcinomatous change?
I think Sven's correct in what he says. I think the fundamental point of this is that cellular senescence is a protective mechanism which is at work in cells so that cells which are damaged by the various means that we have seen are not propagated. And it removes them from the pool of cells which are going to proliferate. So you'll then have a reduction in cells which have got unrepaired DNA damage or in other ways damage, for example, those with mitochondrial dysfunction and so on, and it removes them from the pool of cells which are then available for the regeneration of the tissue. So I guess the question would be that if you think about it in terms of the overall survival of an organism, that it is fundamentally a useful process to have. But that having been said, and I guess there is some discussion about the importance of the SASP and what, for example, you could see as the useful part of a senescence-associated secretory phenotype, which is what tends to give us our pro-tumorigenic phenotype eventually. And I think it probably would be related to the fact that senescent cells, they block apoptosis, and so perhaps the modulation of the local immune response, which can be done by cytokines, will then help in removal of these cells in a somebody whose senescence program is working normally. But I think as we age, our senescence programs do not necessarily work normally. So it's a double-edged sword, as Sven has said, and but I think fundamentally it is a process that the body can remove cells that it no longer sees that it wants to continue to contribute to the population of cells that are dividing in the organism.
Okay, great. And Dr. Safar, do you have any comment or question to share with the experts?
Yes, please. Uh, I wanted to ask from both professors that in the article it's written that, and as we all know, we state that senescence can result in both beneficial and harmful effects. But it's divided into two parts. It says that in young individuals, it's more related to wound healing and cell cycle arrest, whereas in old individuals, it's related to chronic inflammation and maybe paradoxically cancer. I would like to ask that is this can be proposed that cancers that are related to cellular senescence are more commonly seen in old individuals, or since there are other factors, as we all know, and the mechanism is more complicated, this seems a simplistic view, and we cannot propose this comment. I would like to ask about it.
Um, can I go first? Okay, it's basically what Keith said a few minutes ago. That yeah, we were not supposed to, I don't know, thousands of years before, we were not supposed to live till the age of 80. So cellular senescence was a very good mechanism to protect us from tumor development at young stages. But then we are living much longer. These mechanisms, they don't work as good when we get older, and that is why it can be proposed that maybe tumor development in age patients can be related, or some tumors can be related to the tumor promoting effects of cellular senescence. I wouldn't think that in young individuals, cellular senescence can be that tumor promoting, because we are not supposed to have that many senescent cells in young individuals. But senescent cells can also be induced by other factors apart from aging. So, for example, radiation therapy, chemotherapeutics, they can induce cells to senesce, surrounding cells, apart from the tumor cells themselves, and also they can contribute. But yeah, I don't know if I answered the question properly. I don't know if you have anything to add, Keith.
No, thank you so much. Thank you for your explanation. But is there any article who investigated the relationship between cellular senescence in old individuals and in young individuals, and compared that the prevalence in old individuals is more than the younger?
Mm,
I can't think of anything particularly an article to point you to, but I think something which is useful to discuss in this context is the susceptibility of patients who have progeroid syndromes. For example, syndromes like Werner syndrome, Bloom syndrome, and so on, and they do have an increased risk of the development of cancer. So it's not all progeroid syndromes have, and you don't tend to get all cancers. But for example, patients who've got adult progeria, they tend to get skin cancer, sarcomas, thyroid cancers, and so on. And I think that does indicate that when you have the accelerated aging and the accelerated accumulation of senescent cells within progeroid syndromes, that you do get an increased risk of cancer. So it's probably a time related phenomenon. And I can't point you directly in terms of looking at cohorts. And of course, we'll get into discussing the whole concept of quantifying the amount of senescent cells in vivo is incredibly difficult. Um, but I think these more observational type studies, where we know that we're going to increase senescent population earlier in life, probably do point in the direction that you've indicated.
Thank you so much.
Okay, and Mandana, would you please share the question from Dr. Priya? And yes, I would like to ask Sven about the reliability of sentence markers like P16 and P21. Do you have any limitations using this marker? I think it means that do you have any limitation to use this marker?
yeah, that's a very good question. And yeah, there are many limitations, and it depends on the cell type you're working and the tissue you're working. As Keith said, it's absolutely different if you're working with like live tissue with biopsies or if you're working with cell lines. So P16 is one of the most used markers to detect senescent cells. P21 is also commonly used. Um, and when we use markers to detect senescent cells, we should use at least two or three. We can't rely on one. That's the first thing. The most commonly used is the senescent associated beta galactosidase. But the problem with that one is that we cannot use it in formalin fixed tissues, so it has to be a fresh tissue. So it has many limitations if you're working with paraffin blocks. The problem we found with P16 and P21, if we use like oral squamous carcinoma tissues or oral dysplasias, is that it can be induced by HPV infection. You can have mutations in P16. So it's not a good marker to detect senescence in epithelial oral cells because it can be overexpressed by other factors. So, but it can be a really good marker to detect, for example, senescent fibroblasts, because in senescent fibroblasts, it should not be overexpressed. So it depends on the cell type you're working with. And it, of course, it has many limitations. And usually that is one of the issues we have, especially if we're working with live samples. And you need to combine many other markers. You cannot rely on one or two, hopefully two, three, fours. And yeah, it's difficult.
Okay, great. I think there is a problem with my camera. Please, Professor Hunter.
Can I come in on that? So I think what Sven says is correct, and it's a particular challenge for in vivo situations and looking at intact tissues. Although, when Ken Parkinson had managed, there's a paper from a few years ago, particularly looking at oral submucous fibrosis, which is another area that we might get into in terms of the context of senescence, where you could demonstrate these cells, particularly in the fibroblast population, I think quite convincingly. But there's another interesting development that there's a Greek group have published a paper in the Molecular Cell last year with a new marker. It's GLF16. It is a marker related to lipid metabolism in senescent cells. And that marker has just been made commercially available at a rather high price, I have to say. But I guess they have intellectual property to cover, but thankfully we have an agreement with them that we will get some of that from the authors of that paper, and we're just finishing off the AMT at the moment. And we're quite excited about looking at that. And it seems to be more specific, but it also can be
Mhm.
used in vivo. In vitro, certainly in cell culture conditions, but it can also be used as immunohistochemistry in intact tissues. So we're looking forward to getting our hands on that and trying that. So that's quite an exciting area for us.
Could you please let us know the name of the markers?
Yeah, I'll actually. I don't know. Can I share it? Can I share in the chat,
Yeah, you
Please.
if you share it with, on the chat, and I will share it on.
I'll put it in the private chat
Yeah,
to you, Mandana. I'll just put it's a PubMed
yeah,
link,
got it,
and then
got it.
share
Yeah.
that.
Okay, great. And looking forward to reading the paper after publishing it.
I
Okay,
think
it is.
I think it might end up be getting shown at some meetings before it'll be published. But
Mhm.
watch this space. We'll let you know how we get on with it.
Okay. Okay. Great. Great. Thank you. And let me ask a personal question, and then we will go to the question from Professor Hill. Sven, there is a scenario in our mind that chronic irritation may lead to a carcinoma. You well mentioned in your paper that there are several, secretions, for example, cytokines associated with cellular senescence. That's I think that it may be possible to think about the relation between chronic irritation and initiation of carcinoma and progression of the carcinoma. Do you agree with the role of chronic irritation in oral cavity, the role of chronic irritation in oral cavity to initiate a carcinomatous change in oral mucosa?
I think it's all context dependent because for me at least, chronic irritation, I don't consider it to be premalignant or be associated with the oral squamous cell carcinoma. But of course, if you have chronic irritation on top of an oral leukoplakia, of course, that could help for the malignant transformation. But to define chronic irritation itself as a promoter of oral squamous cell carcinoma, I don't believe in that right now. I don't think we have the evidence to support that at the moment. But of course, if you have chronic irritation on top of an oral potentially malignant disorder, of course, that can be promoting.
I would agree with
Okay.
that. And this is, I guess, where I become rather picky about the use of terminology. I think there are two concepts here. There's the concept of initiation. Initiation in premalignancy and malignancy is related to the permanence of DNA damage. And certainly in terms of initiation, I do not think that chronic irritation
Yeah.
has that is something which is completely different. We know the standard features which tend to give these persisting DNA damage loci, but it probably
Yes.
could, on a appropriately susceptible background where the DNA initiating events have happened, be part of the mix that then gives rise to promotion, which promotion has to work on an initiated background. And so then chronic inflammation, chronic trauma, perhaps in terms of the ongoing effects of alcohol, that's where senescent cells are probably going to work. They are not initiators. They are going to work in the area of promoting these lesions to progress, but they're not. And so I think it's careful use of terminology to define exactly what we're talking about in terms of where these might have a place in the process towards carcinogenesis.
Okay, great explanation. Dr. Safar, do you have any comment or question from the audience? I cannot hear you.
Sorry, I was on mute. Actually, I have question, but do you think isn't it better to first consider Professor his question?
Sorry? Could
I
please
have
share?
question. Yes.
Please share his question.
Mm, he has asked that which competing factors are at play in the senescence and apoptosis.
I think if I can pick that up, there's certainly quite a lot of literature showing that a lot the features of senescence are also profoundly anti-apoptotic. So you tend to get in senescent cells when they become stably non-proliferative, which really is the definition of what we're talking about, that there is a block on apoptosis. And so that has meant that when you start having a look at some of the pharmacological agents which may be useful in inhibiting senescence, that one of the ones that tends to come up and has actually been used in some clinical studies are inhibitors of BCL2, which is very important anti-apoptotic marker, which we know much more from hematolymphoid lesions. So I think there are some functional loops in that. It's not an area of senescence that I'm particularly familiar with, but there is a functional link between the two of these, and that is why senescent cells persist and do not. Um, I guess it's an alternative because there are many cases in which cells with DNA damage will be detected by p53 and will then be pushed down a pro-apoptotic route via BAX and so on. But in senescence, that is not the case, and they tend to be protected against apoptosis.
Thank you so much. Do we have time? And can I ask my question as well?
Yes, please.
Uh, I think it's very complicated. First, we say that cellular senescence is associated with chronic inflammation. And when we use senescence therapeutic agents, we try to reduce the amount of inflammation, and in this way, it will help to control the cancer cells. But as we know, there are some inflammatory cells like tumor infiltrating lymphocytes in many carcinomas and in melanomas that they are useful and they are part of the immune system and they are good prognostic factors. I wanted to ask that does we interfere with using senescence therapeutic factors to eliminate tumor infiltrating lymphocytes and cytotoxic T cells that are useful for killing the tumor cells and mechanisms we use for immune checkpoint inhibitors. Thus, these inflammation, chronic inflammation, and inflammatory cells are different from tumor infiltrating lymphocytes.
I think it depends of what drug you use to target the senescent cells, because if you use, for example, senolytics, you will target specifically senescent cells. They will induce apoptosis on these cells. So you will be decreasing the inflammatory component of the senescent cells without affecting the lymphocyte infiltrate. So that in that scenario, that would be ideal. If you use xenomorphics, for example, IL-1 inhibitors or any other inhibitor, of course, you're not selectively targeting senescent cells, so you will be targeting other cells as well, and that can have an impact on the lymphocyte infiltrate. And yeah, maybe it depends for which cancer you're treating, and you need, it's not just adding a drug and see, okay, this works for all cancers. So I think it's very context dependent and cancer dependent.
Thank you so much.
Okay, great. And I think it's time to go to the next video and to hear to the next part of the paper.
Hello everybody, I'm Dr. Aysan Nozheh, Pathology resident of Tehran University of Medical Sciences. It's my honor being here among you, and I want to continue the rest of the presentation. Cellular senescence in pre-malignancies plays two roles as a tumor suppressor and tumor promoter. Senescence as a tumor suppressor. Cellular senescence in human pre-malignancies suppresses tumor growth by preventing indefinite replicative lifespan via inactivating a P16 and P53 pathway. Senescent epithelial cells accumulate in various pre-malignancies like colonic adenomas, cervical intraepithelial neoplasia, Owen's disease, ductal carcinoma in situ, actinic keratosis, and oral potentially malignant disorder (OPMD). OPMD refers to a group of disorders with an increased risk of developing cancer. The global prevalence of OPMD is estimated at 4.47%. Oral leukoplakia and oral submucous fibrosis are the most common disorders associated with oral potentially malignant disorder. Oral leukoplakia has a malignant transformation rate of 9.5%, while oral submucous fibrosis has a rate of 5.2%. A recent study that analyzed 50 oral leukoplakia samples with and without dysplasia found P16 positive keratinocytes in all 50 lesions, which were not related to HPV infection. Senescent markers in 86 oral leukoplakia with different degrees of dysplasia and found that both gamma H2AX and P53 proteins increase progressively according to the severity of dysplasia. In oral leukoplakia with dysplasia, senescent markers such as cyclin D1, MASP, RB, and P16 have been found in higher levels compared to oral squamous cell carcinoma. Senescence as a tumor promoter. Some pre-malignant cells escape senescence through P16 or P53 inactivation, becoming immortal and prone to malignant transformation. Senescent epithelial and stromal cells secrete pro-inflammatory and growth factors as part of the senescence-associated secretory phenotype or SASP. SASP factors can induce partial senescence in surrounding normal cells, creating a pro-tumorigenic microenvironment. SASP factors from senescent tumoral cells, especially fibroblasts, have been shown to promote proliferation, invasion, and epithelial mesenchymal transition in premalignant cells. Cancer-associated fibroblasts, or CAFS. Cancer-associated fibroblasts are a heterogeneous population including activated myofibroblastic CAFS and senescent fibroblasts. Accumulation of myofibroblastic CAFS is associated with poor prognosis of oral squamous cell carcinoma as they support tumor progression, growth, and invasion. Senescent fibroblasts are found in higher numbers in oral squamous cell carcinoma stroma compared to normal oral mucosa and dysplastic lesions. Injection of senescent cells into mice causes persistent dysfunction and spreads senescent to host tissues, likely through SASP factors. Cancer-associated fibroblasts and oral submucous fibrosis. Senescent fibroblasts play a crucial role in the malignant transformation of oral submucous fibrosis, a progressive fibrotic disease caused by areca nut chewing and characterized by a gradual reduction in the jaw opening with an increased risk for oral cancer development. Oral submucous fibrosis leads to a senescence of epithelial stem cells, endothelial cells, and fibroblasts, resulting in reduced tissue vascularity, hypoxia, fibrosis, and collagen deposition. Senescent fibroblasts influence malignancy in oral submucous fibrosis and crucial for developing therapeutic strategies. This figure shows senescent cells promote tumor growth by releasing inflammatory factors known as SASP. Inhibiting SASP components like interleukin-1 pathways could potentially reduce inflammation in the tumor microenvironment, decreasing the risk of malignant transformation in dysplastic cells. Senescence in oral squamous cell carcinoma. In oral squamous cell carcinoma, most of the epithelial cancer cells escape senescence through p53 and p16 mutations to become malignant. A small subset retains functional p53 or p16, but these mortal cells are expected to acquire further mutations or disappear due to natural selection. Senescence of malignant keratinocytes is not naturally expected in oral squamous cell carcinomas or should not have a significant effect in tumor behavior, unless the tumor is irradiated or treated with chemotherapeutic drugs. Immortal dysplastic epithelial cells in oral squamous cell carcinoma are exposed to upregulated SASP factors secreted by senescent fibroblasts. SASP factors such as interleukin-1, 6, 8, and GRO alpha, 6CL1 increase ROS production, favoring cancer development. Mechanisms of cancer-associated fibroblast senescence. In genetically unstable oral squamous cell carcinoma with loss of p53 and p16, keratinocytes produce ROS, which induces oxidative DNA damage in fibroblasts, causing senescence in a TGF-beta-dependent manner. Senescent oral fibroblasts secrete SASP factors that have pro-tumorigenic effects on malignant oral keratinocytes, promoting discohesion, epithelial mesenchymal transition, migration, and invasion. SASP factors such as matrix metalloproteinase 2, ROS, TGF-beta, PGE2, and the MIR 335 COX-2 PTEN axis have been identified to induce these effects. Discussion on cellular senescence and cancer. Overview of cellular aging. Cellular aging is a burgeoning research area linked to organism aging and age-related disorders. Although initially cellular senescence was considered only a potent anti-tumor mechanism, nowadays is also recognized as a potent tumor promoter. Impact on cancer treatment. Senescent cells can influence cancer behavior and treatment tolerance. A study found that senescent marker in T cells before chemotherapy correlated with increased risk of chemotherapy-induced fatigue. In mouse models, the elimination of therapy-induced senescent cells reduced adverse effects of chemotherapy such as cardiac dysfunction and cancer recurrence. Chemotherapeutics. The interest in cellular aging has led to development of new drugs and the repurposing of old drugs. Senolytic drugs specifically target and eliminate senescent cells or their senescent-associated secretory phenotype. Senolytics are drugs that target the SASP without eliminating senescent cells. Senotherapeutics is a complementary treatment alternative for some cancers. Senolytic. Senolytic drugs consist of small molecule agents that target anti-apoptotic pathways overexpressed in senescent cells. These pathways are essential for the survival of the senescent cells but not actively proliferating or quiescent cells. Navitoclox and ABT-737 target the BCL2 pathways. Dasatinib is a tyrosine kinase inhibitor in combination with quercetin reduces the population of senescent cells in mice, attenuating adipose tissue inflammation. AT406 regulates anti-apoptotic proteins CIAP2 and XIAP. In vitro and in vivo models have shown that these drugs eliminate senescent cells and improve clinical outcomes. Xenomorphics or SASP inhibitors. Xenomorphics aim to decrease the pro-tumorigenic inflammatory component of the SASP while conserving pro-immunogenic functions of senescent cells. However, these drugs do not eliminate senescent cells and may require long-term administration as their effect vanishes upon discontinuation. NF-kappa B signaling pathway, which mediates the inflammatory components of the SASP, is common target for drugs including metformin, erythromycin, anakinra, canakinumab, and simvastatin. Inflammation and oral squamous cell carcinoma. Inflammation plays a crucial role in the development and progression of oral squamous cell carcinoma. Increased expression NF-kappa B-mediated cytokines such as interleukin-1 in oral potentially malignant disorder and oral squamous cell carcinoma have clinical impact on outcomes. Besides NF and kappa B, other pathways such as Rho kinase, CGS-STING, and mTOR rapamycin have been assessed as targets for reducing inflammation and senescence-related effects. Interleukin-1 is known as a master regulator of the SASP and plays a role in the spread of Parker's senescence. Animal studies show evidence that interleukin-1 induces malignant transformation of oral precursor lesions and oral squamous cell carcinoma aggressiveness. Future directions. Targeting senescent cells with senolytics or xenomorphics in addition to surgical or chemotherapeutic treatment could be a novel approach for the treatment of oral potentially malignant disorders and oral squamous cell carcinoma. Ongoing clinical trials are exploring the use of senolytics in various cancers, but further in vitro and in vivo studies are needed to validate their effectiveness in oral squamous cell carcinoma. In summary, while cellular senescence has complex roles in cancer, targeting senescent cells presents a promising avenue for enhancing cancer treatment efficacy and reducing therapy-related side effects. And at the end of my presentation, thank you all for your time and attention.
Right. Before we go on with your questions and giving you time to type in your questions, we'll just tell you that you can take part in the journal club by being the presenting team. And yes, Dr. Puyan, you want to say something? Okay, I think we don't have Dr. Puyan's voice right now. It's okay. So, so all right. Basically, a team of three
I
members.
think I'm back.
Okay, good. Yes, go ahead.
Okay, I thank Aysan for her presentation, and I would like to invite all the residents around the world to join this program. Please visit our website and apply for this great opportunity to be in touch with the authors and experts around the world, and you have the opportunity to talk about the details of the highlighted topics in the literature. Therefore, please apply for this great opportunity. I think we will provide it for next year, 2025, and we will get started this program, I think, from the February 2025 again. Okay, Mandana?
Yes, but you can apply. We will be using the names as they come in turn. Right. So let's go on with the discussion. Right.
Sure, great. And let's start this part with the last question of the previous part. Would you share, Mandana, the question from Dr. Rahul? Professor Hunter, would you please let us know if there are any mutations identified in gene controlling telomerase activity?
I think that's a really interesting point to pick up at this point. So, a little bit of cellular background to this, because we know that in replicative senescence, and this is related to work which was done in a number of groups across the world, and Ken Parkinson, who is my mentor, has been involved in many of these. That we know that when keratinocytes become immortal, that there are three main changes that they undergo in terms of the control of the cell cycle. Initially, they will lose the function of P16. Very often, that is removed as the brake on the cell cycle by either promoter mutation, promoter methylation, or subsequently by mutation or deletion. Then the second point is P53 mutation. And we know that the consequences of that has on the cell in terms of control of cell cycle progression at the restriction point. But the third of these is telomerase. Telomeres, as you probably most of you know, are repeating DNA structures on the end of chromosomes. They act as a mitotic clock. They will count up the number of cell divisions, and once they get to a critically short stage, they will also initiate a senescence type response with the cessation of cell division. But we know that telomerase in many cancers is reactivated, and that is part of the progress through the cells becoming functionally immortal. So the focus of this question really is, what is the molecular basis of that? Is it mutation related? Is it amplification related? And for many years, it wasn't really known what was happening, but it's now become evident, I think, that there are, in a number of cancers, not all cancers, but a number of cancers, there have been identified mutations in the promoter of TERT, which is the gene which expresses the telomerase catalytic component. And so we know that this results both in increased expression in some cancers and in increased telomerase activity, perhaps particularly in those cells that have had telomerase switched on normally, that's in the stem cell compartment, and then when they progress to differentiated cells, then that telomerase activity is not switched off, which again allows the cells to progress towards immortality. And interestingly enough, one of the areas, particularly in the oral cavity, where it seems to be very specific, is that TERT promoter mutations have been found very commonly in oral squamous cell carcinomas of the lateral tongue. Now, I don't know why it should be particularly related to that subsite, but that seems to be what the literature is indicating to us. And I think there's still some mileage in that, perhaps in terms of being able to find TERT promoter mutations, if we can do that by sequencing in saliva or so on as early detection and so on. So, yeah, it's an interesting question, and there's a lot still going on in relation to that in terms of the biology of telomerase in many cancers.
Okay, great. Thank you for your explanation. And for the next question about Professor Hunter, well, highlighted the role of P53 in initiation of oral potentially malignant disorder, and also the oral squamous cell carcinoma. I think that Sven, you explained in your paper about the role of evading from the guardian role of P53 in cellular senescence. Do you think that we can use P53 as a prognostic or diagnostic marker or a therapeutic target regarding the cellular senescence in oral potentially malignant disorders?
No, I don't think we can use P53 to detect senescent cells in oral potentially malignant disorders because many oral potentially malignant disorders have mutations in P53. So, and just the overexpression of P53 does not imply necessarily that a cell is senescent. There are many other causes that can lead to overexpression of P53. So I don't know if that was your question, but I don't think P53 would be useful for that purpose.
Mhm. Because it is common among a lot of oral potentially malignant disorders, and it cannot be a specific
Yeah.
target for the diagnosis.
Yeah, it's not specific for senescence. Of course, senescent cells can have overexpression of P53, but not
Mhm,
necessarily because it can be induced by P16, for example.
mhm.
So, and there are many other causes that can lead to a P53 overexpression. So, I don't think it's a good marker for epithelial cells to detect senescent cells.
I would
Okay,
I would
great.
I would agree with that. It's not going to be sensitive or specific enough. There is some really interesting biology about P53, and we could go off on a big tangent here. But and of course, depending on the mutation you have of P53, you can have no expression. If your mutation brings a premature stop codon, and you'll end up with a truncated RNA, which is then removed by the cell by its nonsense-mediated processes, and you can have so it's actually very difficult to then say specifically solely based on expression that P53
Mhm.
how that's why I think there's so much unconvincing and contradictory material in the literature, because many of the papers are focused solely on P53 expression without understanding what
Yes.
the mutational background to that is.
Okay, you're absolutely right. Dr. Safar, do you have any comment or question to share with the experts?
First, I would like to thank everybody for the very nice explanation of the questions. I think we covered all the questions from the participants, but I just wanted to ask if there is any marker available. I know that Professor Hunter is going to share his article, his upcoming article, but is there any marker available to choose and to select cancer-associated fibroblast in the stroma? I mean, something like TGF or matrix metalloproteinase, something like this, to highlight presence and amount of cancer-associated fibroblast in the tissues, in the paraffin embedded tissue.
There are many markers that have been proposed. It's basically the same as senescent cells. There isn't one specific markers because calves are a heterogeneous subpopulation of fibroblasts, but I think the most commonly used is beta actin. No, no, sorry, not beta actin. Is
Smooth muscle
yeah,
lectin.
yes, exactly that one. But again, that's to detect one subpopulation in general, but so many subpopulation. I think at least 9 subpopulation of calves have been described. So one marker does not help to detect all of them. Yeah.
We're using a combination of markers which have come from these published subtypes, and we have some spatial transcriptomic data at the moment on calf enriched areas in some of our cancers, and it has demonstrated exactly what Sven has indicated, that markers, for example, such as periostin, FSP1, and so on are useful in some context, but your fibroblasts are a problem. We do not have a single specific marker which will mark them all. So you have to probably focus down on particular subtypes that you're looking for. And even then, the immunohistochemical expression of these can be quite difficult to interpret. There's a lot of overlap in terms of, for example, for alpha smooth muscle actin, you're going to get that if you've got a area which has got blood vessels which are maturing in it, you'll begin to get pericytes, you'll begin to get other cells that are going to. So it's always difficult to be sure.
Yeah, thank you. Thank you so much for your
Okay,
answers.
thank you. Sure. Let's wrap it up with two questions. First, from Soraya Vamshi, I think she asked that can we rely on EPCAM factor for staging of oral squamous cell carcinoma? Sven, do you have any comment?
I don't know, to be honest. I'm not aware of any studies on EPCAM
Mhm.
factor in oral squamous cell carcinoma staging, so I don't have much to say about that. I don't know if you have something to say, Keith.
I'm aware of the literature which shows that overexpression is related to the development of these cancers, and it tends to be more in large tumors. But I don't have any practical experience of it, and I've no, I can't really comment on that. I suspect that a lot of we don't really seem to use them for staging. I mean, it may be that it's going to tell you something about prognosis, but no, I don't have
Mhm.
any direct experience of using it in any of my studies.
Yes, you're right. And as a last question, Sven, would you please, you well explained about the therapeutic application of solar senescence, this concept, and how we can use it in when we are looking for treatment approach, an effective treatment approach for the people suffering from oral squamous cell carcinoma. Do you explain it in summary? What is our future? How we can investigate it in details? In if we have audience who are interested in following this title, this important topic in their upcoming investigations.
Yeah, sure. Yeah, I guess the main idea of this is to apply or translate what like basic biology research into the clinical practice. So from that point of view, if we have evidence that not in all cancers, but maybe in some cancers, senescent cells or the stroma can have a negative influence or a positive influence in tumor development, then it would mean that we can target that part of the tumor that we are not targeting it, because usually now things have changed, but 20 years ago most therapies were focused on killing epithelial cells, not seeing the tumors as an organ, to say so, because it was just epithelial cells. But now we know that it's not just epithelial cells, so we have also the whole tumor microenvironment that it's not working properly. So the idea, for me at least, would be to add another agent to the chemotherapeutic cocktail, just not to target the epithelial cells, but also to decrease the inflammation that in this case can be detrimental for the patient. So it's not replacing the cancer therapy as we know it. It's just a complementary therapy. That would be my feeling about this approach of targeting senescent cells. Of course, it would not replace, it would not be a single therapy. It's in addition to the therapy we already have.
Okay, perfect. Thank you. And Professor Hunter, do you have anything to add about the therapeutic
I,
application of solar senescence?
I would agree with what Sven has said. I have a postdoc at the moment who's working on using senescent fibroblasts in co-culture with epithelial cells, so we know, for example, their sensitivity to cisplatin into radiation, and to see whether the addition of these senescent fibroblasts will increase the resistance, which that is our hypothesis that it would do, and that would then give some good evidence to the fact that it would be useful if we could target these senescent cells. For example, it may be in a sort of neoadjuvant setting. If you can target the senescent cells before a patient starts their chemoradiotherapy, that you might find something that's quite useful in terms of ensuring a good response.
Okay, great, great. Thank you very much for your great contribution. And Mandana, we are ready for the next step. Okay, first, the certificate of appreciation. Thank you very much, Sven, for sharing your time and knowledge with us. It's a great pleasure to join Oral Pathology 360, and it was a great paper. And I would like to invite all the audience to review this article again in details, and it was very interesting. Thank you, Sven, for being with us.
Thank you very much for the invitation. A pleasure.
It's our pleasure. And the next one, okay, let's go. I cannot see the next one yet. Okay, great. Uh, Professor Hunter, I do appreciate your generosity to share your time and knowledge with us. Thank you very much.
Thank you, Pouyan. It's my pleasure as always. Thank you, and thank you, Mandana, for inviting me.
And the next one, thank you, Dr. Safar, for your time and attention. You always be with us for this program, and I'm looking forward for the next one in upcoming future.
My pleasure. Thank you so much for inviting me.
Great. And I would like to let me go to the next one. I cannot, okay.
It's on,
Who is the
Dr.
next one?
Masume. Dr. Masume.
Okay. Masuma, do you have any question or comment to share with the experts? Masuma, do you have my voice? I cannot hear.
I don't think she's connected.
Okay. Anyway, I would like to thank you for preparing such a great presentation, Masume. And let's go to the next certificate of appreciation. Thank you, Aysan, for your great presentation. And do you have any comment or question to share with Professor Niklander and Professor Hunter?
No, I haven't. Thank you, everyone. It's my honor being here among you, and it's my pleasure in being in this professional team. Thank you.
You're welcome. Thank you for being with us. And Mandana, the
Yes.
stage is yours.
Thank you. So let me thank all of you. It's been a pleasure as always having you with us, Keith. And it's always great when you come back. And I hope you will come back many more times. And it was great having Professor Sven also with us first time, but I hope he will come back too. And Dr. Safar, thank you for being with us again. And of course, our two residents. And last but definitely not the least, Dr. Pouyan, whose child this whole program is, and it is entirely his brainchild and it's his show. So thank you all. It's been wonderful. And we have one last comment from Professor Hill, which basically is encouragement to go on with this work. A lot more research work should be initiated on the relation of senescence and oral cancer promoted driven by chronic trauma. So this is seems right to wrap it up, and it was really wonderful having everyone. Now we just have to say what we are doing next. Yes, in November, this will be our interactive journal club 8, targeted therapies in amyloblastomas and amyloblastic carcinomas, a systematic review. I hope you will join us for that. And now, before I go on to tell everyone how to get their certificates, I think I will let everyone else say bye. I don't want to take your time. So it's been wonderful. See you all soon again. Take care.
Bye bye.
Bye
Thank
bye.
you.
Bye.
Thank you.
Thank you. Bye. Bye. Right. So, for all of you who are waiting for your certificate, what you need to do is first, of course, you should have joined you should be a channel member. For that, you hit the join button, and there are three options. From there, you can choose which one you want to follow and which level of membership you want to join. And after you have done that, there is a link that is visible to members only on the community tab. When you go to the channel, you can see the logo of the channel below the video. If you click on it, and it will open, you can then scroll on top and see the tabs which says videos live, and one of right at the end is community tab. There you will see a link already where you can get your certificate. If you have any problems, of course, you can email me or you can message me. And I think that's about it, and we are done. Thank you all so much for being with us. See you all soon. Bye bye. Have a nice time.